Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each presentation will be followed by a Q&A. Use the chat feature to submit your question. If you encounter technical difficulties during the summit, go to the navigation menu and select the Need Help button. Now I will turn it over to our first speaker.
Great, thank you. It looks like we've still got some folks rolling in, so I will just begin sharing my slides and give folks a minute to get in. So I guess while we're waiting to do that, I will introduce us. This is the we're going to be talking about access to care for individuals with opioid use disorder. Very briefly, we're going to give you kind of the 30,000 foot view and a little update of what's been going on and some thoughts for the future. So I'm Corey Davis. I run the Harm Reduction Legal Project, and I'm Deputy Director of the Southeastern region here at the network. And also joining me will be Amy Lieberman, who is a senior attorney here at the Harm Reduction Legal Project at the Network for Public Health Law. So what are we talking about? Well, as you know, most of you who are on this webinar know, we've got two public health emergencies happening at the same time, right? We've got the opioid overdose emergency, and we've got COVID-19, the novel coronavirus. There were somewhere around 70,000 overdose deaths last year, probably more. About 50,000 of those were due to opioids, and this year is looking even worse. There was a public health emergency declared in October of 2017 related to what the emergency calls the opioid crisis, and it's been renewed more or less continually since then. Of course, we also have the COVID-19 crisis that's killed 200,000 people, give or take, in the United States. And there's a public health emergency and a national emergency associated with that crisis. Both of these epidemics disproportionately harm disadvantaged groups, particularly people with disabilities, people of color, low-income people. And they are both epidemics that are made worse by lack of access to evidence-based interventions. And I would also add, made worse by some people pushing things that actually don't work. So not only denial of access to things that we know do work, but also insistence on interventions that simply don't work and are likely to make things worse. So, some comparisons between the two, right? So social distancing is really important. Wearing masks, staying away from people is one really good way to reduce COVID-19 risk. Unfortunately, social interaction can actually be a protective factor for people with opioid use disorder, people in recovery. Routine is important. Access to groups is important. Access to counseling, just seeing friends, having social connections. Those can all be protective against opioid use disorder and opioid-related harm. So, the same things that are protective from COVID-19 can actually be harmful for opioid use disorder. And that includes things like being able to access syringe exchange and so on. There are also differences in medication prevention and treatment. So there are some things we're learning, some medications that can, for some people, decrease the severity of COVID-19, but they're not that great. They don't work for everybody. And of course, we have no vaccine yet. On the other hand, we have really good treatments for opioid use disorder, particularly these things we call opioid agonist therapy or opioid agonist treatment with these medications, methadone and buprenorphine. Those medications are very effective. They reduce overall mortality by about 50%, not just overdose mortality, but your probability of dying from anything. Cut it in half. I mean, that's a tremendous intervention. And of course, also reduce other harms and risks associated with drug use. And as most of you know, there's also a medication called naloxone, often known by its brand name Narcan, that quickly and effectively reverses acute opioid overdose. So this is a big difference between the two. You know, we are working feverishly on treatment for COVID, but we're already there with opioid use disorder. So it's not a lack of treatment, it's a lack of access to treatment. So what are those, where does that lack of access come from? What are those barriers? Well, for naloxone, the big barrier is that it's a prescription medication. It's not a controlled substance, but it does require a prescription. That means that we're dependent on either the FDA or the federal government to move it over the counter, which so far they have not done, or states modifying state laws to kind of work around that requirement to make it easier to access naloxone, even though it's still over the counter. With syringes, of course, the problem really here is stigma. It's the war on drugs. We know that having access to syringes does not increase drug use, does not increase crime. All it does is prevents people from transmitting bloodborne infections, from getting sick completely unnecessarily. But most state laws make it illegal to have syringes. Most states have some sort of carve out for syringe exchange programs. They're very limited and incredibly discriminatory. They still come from the standpoint that syringes are bad and we want to make it difficult to access them. There's no public health basis for that. That is a law that is designed to increase bloodborne disease transmission. That's what those laws do. Buprenorphine has a fair amount of limits at the federal level. Unlike almost every other prescription medication, even if you're a physician, you've gone to medical school, you're out there practicing, you can prescribe oxycodone, hydrocodone, all those other opioids. You need to go to a special training to prescribe buprenorphine. It takes a whole day for doctors, 3 days for other prescribers. Then once you get that, there's limits on the number of patients you can treat. There's also a federal law that says that before you start treating people with controlled substances for the first time, you need to have an in-person interaction with them. This was designed to cut down on these sort of rogue internet pharmacies. It may be a good idea in and of its own, but it's another barrier for people who are trying to access buprenorphine for opioid use disorder treatment. We have a lot of people in this country who don't have access to broadband internet. This law, well, we'll talk about that in a second, but it's a big problem because in practice, this law has a carve out for having that first interaction via real-time audio-visual means, which to those of us who kind of live in a big city and have a laptop doesn't sound like a big deal. If you're living in a rural area and you have dial-up, it's absolutely impossible. If you are unsheltered, it's basically impossible. We have a huge digital divide in this country. Still, and here you can see a visual representation of that. This is buprenorphine providers per capita. You can see just the huge disparities here. Some places have relatively good coverage. Huge areas of the country, particularly in rural areas, just have very, very bad coverage. Methadone is even worse. Federal law puts huge barriers on access to methadone treatment. It can only be dispensed through these things called opioid treatment programs, which need to be registered, licensed by the federal government. There are limits on who can access methadone through those facilities. There are limits on how much methadone they can be prescribed. There's requirements for how often people have to come in. When you start methadone treatment, you have to come to the opioid treatment program every single day. Makes it very difficult to have a job. Makes it almost impossible to get methadone if you do shift work or have work that has shifting hours. Again, if you were designing a law to make it hard for people to do the right thing, you would write a law like this one. And states often impose their own limitations. These are important, right? These are barriers to evidence-based prevention and treatment. It is harder to get methadone or buprenorphine for opioid use disorder treatment than it is to get any other medication, almost any other medication. Certainly much harder to get the medications like oxycodone, hydrocodone, prescription fentanyl that are actually, increase overdose risk. You can see here, it is just difficult to get this. You make it harder for prescribers to prescribe buprenorphine. You're going to have fewer prescribers that are prescribing buprenorphine. Like I said, there are huge disparities by geographic area. It's a lot more difficult to access these medications if you live in a rural area. There are also barriers by race. We see from the data that, like everything else, there are, stigmatized programs are pushed onto stigmatized people, right? So methadone clinics are often pushed off into, undesirable areas, and they are disproportionately accessed by people of color. White people are much more likely to access buprenorphine, which doesn't require going to this sort of stigmatized place and waiting in line. You can get it from your doctor's office if they're waivered. So we just see this perpetuation of already existing disparities. How long does it take you to go to an OTP, to a methadone clinic versus going to a pharmacy? And no matter where you are, it's much more easily accessible to go to a pharmacy than to go to an opioid treatment program. So we're making it harder to get medications that treat opioid use disorder. Now, there have been some changes related to COVID-19. Some states have temporarily lifted some limits on syringe and naloxone access. Usually this is going from really bad to just kind of bad. For example, we had some states that required 1-for-1 exchange. That is, you can only get one syringe back for every syringe that you take in. A couple of states, Maine, North Dakota, have changed those. Pennsylvania has changed its naloxone standing order to permit naloxone to be mailed, which is really important because it's hard for people to go to a pharmacy or go to a harm reduction program that's giving out naloxone. These are just really common sense things. You shouldn't need a global pandemic to put these things into place. The federal government has also made some changes. The HHS secretary has waived that in-person requirement before initially prescribing a controlled substance with relation to buprenorphine. The DEA has also used its regulatory discretion to permit that to happen via telephone instead of that audiovisual requirement, which is really helpful. It's getting a lot of people onto buprenorphine. And HHS has, basically said, look, if you're trying to do the right thing, we're not going to strictly enforce the HIPAA requirements regarding approved telecommunications devices, which is great, right? We don't want people not to be able to see a doctor because they can't install the right software and that sort of thing. Here you just see, again, that real lack of access to broadband internet, to the capability of having a real video interaction, right? So the idea here is that we don't want to let the perfect be the enemy of the good. It is much better to be able to talk to a prescriber over the phone than to just say, you're not going to be able to talk to a prescriber at all. Same with methadone. SAMHSA, which has some regulatory discretion to set the standards here, has waived that requirement that most people come to the methadone clinic every day. A lot of people are now able to get what we call 14-day take-home, so you can get 14 days of medication. People who are stable, who've been there for a long time, can get up to 28 days. DEA has also permitted some delivery, although it's quite limited. States often have their own limitations on methadone. Some of them have waived some of those. It's a total patchwork. And of course, these requirements, these permissions are dependent on states that have more restrictive laws modifying those laws. And of course, in the facilities themselves, right? These are not requirements. These are permissive changes. So clinics can, if they want to, still require people to come in every day. And of course, the big problem with these is that these are all emergency actions. They will all shift back to the old, more restrictive regime once the COVID crisis ends. Most of them are tied directly to the federal opioid crisis, public health emergency. Eventually, thankfully, we will make progress in COVID. That emergency will be lifted. But unfortunately, at that time, all of these other things are going to snap back to where they were before. And with that, I'm going to let Amy take over.
Hi. So we want to talk about now what happens after that COVID-19 emergency ends. I'm going to go through this a little fast so we can address any questions you have. But it's obvious that permanent change is needed. The opioid-related harm crisis existed long before COVID-19 and will continue to exist after. Additionally, COVID-19 is almost certainly increasing the risk for people with opioid use disorder. So far, more than 40 states have reported increases in opioid-related mortality as of just this month. Additionally, some people with opioid use disorder are at increased risk for COVID-19. So while there's not much research yet, all of these signs point to making these changes, improving the outcomes for people who use drugs, and that we want to permanently remove these barriers to opioid agonist treatment through legislative action and regulatory action and use of regulatory discretion. Some examples of that would be, thank you, Corey, that Congress, legislative change, Congress can make these changes permanent. The TREATS Act has been it expanded the telehealth provisions, but it still requires at least video for initial evaluation. And Corey discussed how that's an issue for people in underserved communities. And just being on the telephone, that kind of initiation is very important. Most limitations on opioid agonist treatment actually reduce patient and public health. The legislature can also take positive steps to increase access to treatment. For example, conditioning funding to states on ensuring that opioid agonist treatment is available at all correctional settings. Regulatory changes that can be made is HHS can tie the Ryan Haight Act waiver to the opioid emergency instead of the COVID emergency. The DEA should continue the telephone exemption for the length of the opioid emergency. DEA is also required to create a special registration for telemedicine providers, but has failed to do so, and they should quickly promulgate rules permitting the prescription of buprenorphine via telehealth. And the DEA can change their regulations to permit mobile methadone delivery. But state and local changes are going to be needed as well. Many states have modified their telehealth provisions, such as mandated payment parity, authorized use of audio-only visits during COVID, but those should remain. Some states have increased accesses to syringes and naloxone. To the extent that state or local law is more restrictive than federal law, permanent changes should be made, like setting Medicaid rates at reasonable levels, requiring all licensed providers to obtain waiver. It could be a part of your requirements for getting your license. Ensure that all justice-involved individuals are screened and offered opioid agonist treatment if indicated. Established central telephone numbers to reach buprenorphine providers, and exchanged criminalization for public health approaches. Diversion seems to be an issue for people, but diverted buprenorphine is nearly always used to reduce the use of other opioids and treat withdrawal. It occurs because there's not enough providers to serve people, and there's just evidence that a greater frequency of non-prescribed buprenorphine use is significantly associated with lower risk of overdose. The problem is almost always too little opioid agonist treatment, not too much. We know what works. Everyone who wants opioid agonist treatment, naloxone, and new syringes should be able to access them. COVID-19 has exacerbated these existing inequalities. We need to address stigma, financial barriers, and structural inequalities. Federal, state, and local governments can and should remove the legal and policy barriers and replace them with things that work. Failure to do so is knowingly and intentionally increasing the risk of overdose and other harms. For naloxone via mail, you could see Next Distro at nextdistro.org, and to sign a letter asking Congress to increase access to buprenorphine, if you click the link, you can follow that to sign the letter. Give a few minutes for questions.
Yeah, and I would say we are, both Amy and I are going to be on the town hall thing this afternoon and another one tomorrow. So there's plenty of time to catch us, and we're happy to talk to you. We're also happy to answer your questions via email. So if you have questions, I think the way to do that is just to throw them in the chat box, and we can see them, and we will answer them.
Corey, I see someone asked about pharmacy dispensing for methadone and a proposed rule for mobile methadone.
Yeah, so what about pharmacy dispensing for methadone? Yeah, so the problem with that is that, like I said, the federal government requires, in general, that methadone only be dispensed from what we call an opioid treatment program, one of these federally licensed facilities. There is a part of that that says that the methadone, they're called OTPs. I mean, colloquially, we call them methadone clinics. So I'm just going to use that term. There is a provision of that says that a methadone clinic can have what we call a satellite facility, where you can't start methadone, you can't do any of your other requirements, but it can be dispensed. There are some pharmacies, including several in California, that are satellite facilities. So you can get your methadone from the pharmacy. So it is possible. If you are interested in that, we're happy to talk to you and put you in touch with folks who have figured it out. But legally speaking, those are just sort of a satellite dispensing area from a licensed pharmacy. So you still need to be able to go to the OTP for your intake and for if they require counseling and those sorts of things. Whatever happened to the proposed rule for mobile methadone? It's still hanging out there. It's still hanging out there. That's all. That's as much as we know, as much about that as you do. There is a question about permitting take-homes for methadone from a shelter. I mean, yeah, so these are all, that is a change that was made as part of the public health emergency. So that is scheduled to go back to the old rules after the public health emergency is lifted. There's a question that says, I'm teaching a bunch of law students and trying to get them tapped into the voice of folks seeking and receiving MAT. Do you have any good resources for lifting the voices of folks navigating OUD? I mean, yeah, there are some great user groups that can, talk not only about people who are accessing opioid use disorder treatment, but also, people trying to get naloxone, people trying to access syringes. We actually had a webinar a few weeks ago, maybe a month ago, where we had Louise Vincent from Urban Survivors Union. They are a great resource. She actually talked specifically about this issue, about how difficult it is to access, particularly methadone. You know, like we said, the federal government has done, you know, basically what it can, given its regulatory authority, but it's still up to states. It's still up to the particular clinic, whether they want to let people get take-homes, whether they want to create a welcoming environment where people want to go, as opposed to sort of a almost a carceral environment where it's assumed that people are up to no good, that people should be shamed, that people need to be tightly controlled. I mean, the federal government could do something about that, but so anyway, I would suggest you check out groups like the Urban Survivors Union. That's a national group, and they have a number of sort of more local or state chapters. That would be my suggestion. How has stigma surrounding methadone and other drug treatments been exacerbated by the COVID-19 pandemic? You know, I'm not, you know, I don't know. I mean, I'm not sure that that's true. I mean, stigma was huge before. It's still huge. I would say that, you know, to some extent, the laws, the regulations, the policies that are in place are informed, they're driven by stigma against people who use drugs, you know, and the epidemic is just, you know, is making the restrictions put in place by those laws, rules, and policies even more dangerous, even more deadly, right? Because part of them, you know, they're very focused on control, you know, like lots of in-person meetings, you know, lots of, you know, you need to come to a particular place and piss in a cup for us, you know? I mean, that is a barrier in the best of times. It's an even bigger barrier during COVID times. You know, people are, besides the, you know, providers are closed, it's hard to social distance. You know, people are losing their jobs, which means they're losing their insurance. You know, there's just this cascade of barriers. I don't know, Amy, do you have any thoughts? I mean, I'm not sure that, you know, stigma is being increased.
I'm not sure. Yeah, I don't know how much it could be increased from the baseline level of stigma that's out there right now. But I think that yeah, I'm not sure about that. I think it's become much more difficult to access those treatments that people may want to seek out, but I don't know that they're seen, people who use drugs are seen any differently than they were prior to the COVID-19 emergency.
Yeah, so I'd say we want to be respectful of the time, so we're going to turn it over to Jill at this point. Like I said, we are, both Amy and I are going to be part of the Southeastern region's Q&A networking session that's going on this afternoon, and we also have a session tomorrow afternoon, so we'll be there. Just come up. It's just informal, and we're happy to answer any questions that you might have, and interested in hearing from you as well. So with that, I'm going to turn it over to our colleague, Jill Kruger.
Thanks, Corey and Amy. Really glad to be here with folks today and talking about addressing mental health and well-being during the COVID-19 pandemic. And let's see if I can share my screen. Michelle, am I doing it correctly?
It does not appear.
Okay, let's see.
We click the share screen and then whichever browser has your presentation.
Okay, is that working?
Yes.
Okay, super. All right. So yes, we're going to be talking about legal strategies for promoting mental health and well-being in the COVID pandemic. And let's make sure I know how to advance slides. Sorry, folks. So we're going to be talking about, you know, kind of some of the things we all know. I mean, because we've all lived through it, right? Some of the mental health impacts. And then we're going to talk about legal strategies that people may not be familiar with. But Michelle, I could really use, can you help me figure out, can you tell me how to advance the slides? Or do I just, okay, so great. This is just the obligatory, if you're someone who tweets, here's how you can do it with the hashtag COVID-19 policy playbook, brief infomercial there. So a roadmap for what I'll talk about briefly during the next 20 minutes or less. Again, some of the background on the mental health impacts, and then just a series of strategies that folks may or may not be familiar with. And they're listed up there, and we're gonna start marching through them. So one of the things you often hear about in terms of mental health responses to things like the COVID-19 pandemic or other you know, disease outbreaks, natural disasters, people can say, I haven't felt like this before. And one thing it's helpful to do is just to normalize it. These are normal reactions to awful situations. And when we're in this pandemic, there are deaths, there are illnesses, there are fears of death and illness. And so it's totally normal. It's not a sign of mental illness for people to feel some anxiety or waves of grief, fear, perhaps even survivor guilt if they get COVID and recover, or get COVID and are in a recovery process and it's really hard and they struggle with that. And then there are the more widespread impacts resulting from the economic disruption and the anxiety people have felt from that, or the denial of the reality of the pandemic as a coping mechanism. You know, maybe a maladaptive coping mechanism, but a coping mechanism all the same. You know, people are struggling with the isolation, and at the same time, folks who live with others may be experiencing a lack of solitude as there are lots of people, you know, confined in the home together, or a loss of freedom to travel and to do the things we're used to doing. And the exhaustion factor of online everything, you know, Zoom fatigue. And then I can't not acknowledge racial disparities as part of these awful situations compounding the stress, particularly for people of color. Now, there may be protective factors for many members of communities of color as well, but you know, racial trauma resulting not so much perhaps from the pandemic itself, but we've got, you know, as Corey and Amy were talking about the co-occurring epidemic of drug overdose, we've got co-occurring concerns with racism, structural racism, police violence. And so some of the experiences there have also contributed to the mental health burden experienced by many Americans. So a team of researchers in Canada, including Stephen Taylor, who had authored a book on the psychology of pandemics before the pandemic hit, the COVID-19 pandemic hit. This spring, or perhaps this summer, they coined the term COVID stress system and identified 5 factors that might be present in an individual experiencing this kind of suite of symptoms, not just fear of COVID-19, but coupled with socioeconomic concerns, either from loss of a job or reduced hours or loss of childcare. So a continued job, but also trying to do the job while caring for a child, or perhaps for a family member who's ill, and traumatic stress associated with the pandemic. Now, the research team identified xenophobia as a possible, one of the core factors of COVID stress system. That might be fear of all others. It might be stigmatizing Asian Americans, or in Canada, people of Asian descent, particularly those of Chinese descent, as some racist depictions of the virus associated with the early outbreak in Wuhan, China. And then compulsive checking and reassurance seeking, people who are just constantly checking the news, perhaps, what are the latest statistics, both, perhaps in my country or my county or my province, my city, my state, and trying to seek some reassurance that, what's my relative safety compared to others. So they identified this as a suite of syndromes, a suite of symptoms that they called COVID stress syndrome. But again, many of these, not all of these, but many of these are normal reactions to awful situations. So if we think about that, what kinds of things can help people who are experiencing these normal reactions to these awful situations? And the field of positive psychology has done a fair amount of study. And one of the leading scholars, Corey Keyes, has developed is this dual continuum model, which says that mental illness can exist on an axis separate from mental health, so that a person can have mental illness, but still have good mental health. They can be flourishing. Similarly, someone may not be mentally ill, but they may be what Keyes calls languishing, not having good mental health. And then other scholars in the field of positive psychology have attempted to identify what kinds of activities contribute to flourishing. And they've identified a set of 6 activities: interacting, helping others, playing, moving and physical activity, spiritual activity, and learning something new. And then you look at that set of activities and you think, how many have had an impact, have been affected adversely by the pandemic and the community mitigation measures that have been put in place? And you can see almost all of them have been affected in one way or another. Now, some of them we can still participate in by online, but it's different. So that helps to understand why there's been a pressure, and such extraordinary pressure, to people know they're not doing well, they know their mental health is not good, and they want to be able to do these activities. Now, here's a similar list, but this list is from the research on mass trauma intervention. So some of these principles are like those flourishing activities, but they help us think in more of a population rather than an individual perspective. So in terms of mass trauma intervention, the kinds of things we want to do are promoting a sense of safety, promoting calming, promoting a sense of self and collective efficacy, connectedness and hope. So these kinds of things, if we have these 5 principles in front of us, they can be kind of an assessment or evaluation framework, or an inspiration, a guide to the kinds of policy and legal interventions we might want to effectuate. Now, Anthony Jorm is one of the founders and originators of the mental health first aid curriculum and approach. And what Jorm says is that it's important to note that mental health literacy is not simply a matter of having knowledge. It's knowledge that is linked to the possibility of action to benefit one's own mental health or that of others. So we're not here just to learn about this, but we're here to learn, at this entire virtual summit, what can we do better? So let's then turn to some of these legal and policy interventions. The first is psychological first aid, and I'm guessing that this might be one that some folks on the call are already familiar with. It's an evidence-informed approach to increase knowledge, skills, and ability to support individuals and communities during and immediately following traumatic events. And it's an intervention that can be implemented with anyone. And in particular, we've seen it be successful with first responders, with healthcare providers, and it's been effective. And I'd be interested perhaps in the Q&A or the later Q&A discussion at the end of the day, what people's experience has been with psychological first aid. And there are specific policy interventions that can support or already have supported psychological first aid. Now, under the Pandemic and All Hazards Preparedness Act, the original one, there was funding for centers at schools of public health to develop training for psychological first aid, but that funding has been discontinued. There's been, as part of the hospital preparedness program, psychological first aid has been a deliverable. And in fact, as part of the work at one of these PERC centers at University of Albany and SUNY New Paltz in New York, I cite to an article that came out of this that was specifically through a PERC grant or cooperative agreement studying policy to promote psychological first aid in local health departments and hospital and healthcare system policies. Another important core for the psychological first aid is the National Child Traumatic Stress Network, which has also had legal and appropriation support through the 21st Century Cures Act. So an important adjunct to psychological first aid is it's first aid. It's an emergency treatment. Now there is a lesser known companion to the psychological first aid called Skills for Psychological Recovery. And as the pandemic extends, those approaches are increasingly important as well. Now, the Crisis Counseling Assistance and Training Program, or just the Crisis Counseling Program, is another program to be aware of. Historically, it's been accessible under the Stafford Act when there is a major disaster declaration and not for public health emergencies. But because in the case of COVID, we have had a presidential major disaster declaration, the Crisis Counseling Program, I'm just trying to keep track of time here, the Crisis Counseling Program has been made available in states that have requested it. Now there are some needed changes there in terms of the law. I would argue that the Stafford Act should be amended such that the Crisis Counseling Program can just be directly available when there's a declaration of a public health emergency. In addition, the Stafford Act language limits the Crisis Counseling Program to a period of 9 months after the declaration of a major disaster. Now again, when there's sort of one event, there's a hurricane, for example, that kind of timeline may make sense. But as this COVID pandemic continues and the mental health burdens increase, it may be time to revisit that 9-month limitation on the Crisis Counseling Program, and additional funding and support and frankly, publicity and elevation of this program should also be considered. Now, you'll recall both that example about interventions for mass trauma mentioned addressing the practical concerns that people have. You know, do they have food? Do they have clothing? Do they have shelter? And those are all the kinds of things we think of as social determinants of mental health, that these practical and physical considerations are directly related and connected to and impact upon people's emotional and mental well-being. So, you know, the agenda for this virtual summit, top to bottom, is filled with aspects of the social determinants of mental health, some of which are listed here, and again, many of which are addressed throughout the conference agenda. So I will not take time here to go through each of those interventions, except to emphasize that these interventions, which are directly related to these specific physical and practical considerations, then have a co-benefit of improving and stabilizing people's well-being and mental health. Now, in terms of access to care for mental health, Benjamin Miller, who's the Chief Strategy Officer at Wellbeing Trust, has been quoted as saying, before the COVID-19 crisis, America's infrastructure for mental health and addiction services was fragmented, overburdened, and underfunded. As you might guess, none of that has improved over the last 6 to 9 months. That said, there are legal and policy levers to address and improve access to mental health care, some of which have been utilized in the last number of months, and some of which remain to be accessed in the future. Mental health parity is still more recognized in the legal, on paper than in actuality, although the state of California has been making recent moves in that direction. There has been significant progress at the Centers for Medicaid and Medicare in loosening some of the restrictions, some of the barriers to expansion of telehealth, including telemental health. We do have another separate session. Kason Schmidt is leading on telehealth. So I'll defer an in-depth discussion of that. And there are some other state-specific remedies that we could discuss in the Q&A if people are interested. As I said, telehealth is addressed in a separate session. School mental health is a critical context for promoting mental health. And many of the interventions that are in place in the school setting, from direct individualized mental health care and services, were disrupted with the move to remote learning that took place almost nationwide in the spring, and in many places is continuing into the fall. So it becomes critical to think through what are those interventions and supports and how can we translate them to the online setting. One of the leaders in the field of school mental health is CASEL, the Collaborative on Academic, Social, and Emotional Learning. They have a 5-part framework of the elements of social and emotional learning. And they've been hosting a series of webinars and producing materials on how to translate SEL to the online environment. Some of their close partners, for example, Austin, Texas, has created an entire website of resources that may be utilized in other jurisdictions or may give inspiration. So really critical sets of resources there. Similarly, the state of New York and Virginia both have laws requiring, to one extent or another, that mental health be addressed in the curriculum of health education. And so this is a screenshot from the state of New York, their school mental health resource and training center. And again, a wealth of resources there. They've created specific, collected and created new resources for school mental health during social distancing, all made possible, again, by that initial law requiring that mental health be addressed in health education. And so they were already in position then to pivot to address the additional complications of social distancing. Mental health first aid training for teachers in the state of Florida, partly as a response to the Parkland shooting. Florida has been ramping up in-person teaching. I think some of that may have shifted to remote training, but to assist teachers to identify when their students may in particular be really struggling with mental health concerns, whether that be anxiety, depression, or any number of other concerns. One sort of looming iceberg that I don't think we've tackled, excuse me, I do want to have plenty of time for Q&A, or at least insofar as we are able to in these sessions. But I do want to just briefly note a couple more things before turning it over. But if any of you have questions that are percolating in the back of your minds, feel free to start typing those into the chat now. Again, I've already mentioned the Wellbeing Trust. They work with other partners to really, over the last few months, begin digging into the concern about possible deaths of despair related to COVID-19. And they predict that it could number into the tens of thousands. Now, what I will say is this is National Suicide Prevention Awareness Month in September. There has been a move, it'll roll out over the next 2 years, but a move toward a new National Suicide Hotline Designation Act, 988. And we have a whole slew of evidence-based suicide prevention strategies, whether that's federal funding through the Garrett Lee Smith Act for states and tribes and local governments to implement evidence-based suicide prevention strategies. This has been studied extensively, and comparisons show that those jurisdictions that have the funding do have lower suicide rates. Red flag laws or extreme risk protection orders. States as diverse as Connecticut and Indiana, which have red flag laws. These are laws that prevent, that can restrict the access of people who are shown to be a danger to themselves or others, restrict their access to firearms. So means restriction is an important suicide prevention strategy. There are other suicide prevention strategies that we can examine and implement. I'm happy to discuss that later. And my colleague, April Shaw in the Northern region at the network is beginning to dive into and create a series of fact sheets on some of these interventions. And we talked in terms of principles of mass trauma intervention of the need for strategies for post-traumatic growth. The idea that out of adversity, people can actually grow. And there have been studies show personal growth. There have been studies coming out of Hurricane Katrina, Hurricane Sandy, survivors and healthcare providers out of the Ebola epidemic. And there are strategies, those studies show evidence of people or veterans. There's been a national study of veterans experiencing post-traumatic growth and the kinds of interventions, whether it's individualized counseling or more of a public health population-wide intervention that can help stimulate that, that kind of post-traumatic growth. So there is hope. We can always return to core principles of how we can improve people's mental health, and that's strong relationships, reducing sources of stress, including those physical conditions that can contribute to financial and other stress, strengthening core life skills. So yeah, the chapter in the policy playbook does go through a lot of these key recommendations. So I'm going to see if I can toggle back and see the some of the Q&A here, that if any's been coming in, or perhaps you can assist me, Mashalawa, if you're seeing any as well. Stop sharing screen. Okay, chat. Let's see. Okay. Sorry, I'm having a little difficulty navigating the chat here. Okay, well, let's think about some of the other questions that we could address. So I mentioned briefly school mental health interventions. Another one that the state of Oregon recently passed was allowing mental health days, sick days, excused absences due to mental health concerns. And it may be with the advent of remote learning that other states will want to examine that intervention in terms of for their states to provide that same, again, it's this notion of parity. If a student is experiencing the stomach flu or has a migraine, no one questions that they're not going to attend school that day, that it's appropriate for them to stay home, to rest, to get exercise if they're able physically, to eat the appropriate nutrition and try and heal and recover so they're ready to come back to school. So Oregon has adopted that law. as a strategy to support mental health in that context. Let's see. Okay, another question might be relative to the to psychological first aid, if there are any resources. I've received questions whether psychological first aid, if there are culturally specific resources, and I can, excuse me, add those later to the website. I haven't yet done that, but there have been a number of resources developed for culturally specific trainings in psychological first aid to address particular concerns and strengths in varying racial and ethnic communities, addressing particular challenges and assets that those communities might have. For example, here in St. Paul, there's a collaboration between one of the local healthcare systems, mHealth Fairview, has worked with cultural brokers based in community-based organizations, also to provide mental health first aid training that is culturally specific. So that's more of a policy intervention than a legal intervention, but just illustrates that there are avenues to tailor some of these interventions to be most meaningful in a particular community, and really gain the benefits there of assisting with people managing the stresses of this time. Okay, let's see. Looking for any other questions. And it's possible that, I don't know, we've got a couple of minutes left here. So I really invite people to submit questions through the chat if you have particular questions, or you know, want to weigh in on the kinds of, you know, are people working predominantly in the area of mental health? Are you curious about what kinds of strategies you can implement for your own staff? You know, as public health workers themselves and healthcare workers are, you know, looking at months, you know, 6, 7, 8 months of this work and no end in sight. Some may be looking for strategies. And again, psychological first aid, perhaps there was a training or a series of trainings that were offered back in March or April or even May. It may be time to start another cycle of that, look at skills for psychological recovery as a continuation. It can't hurt to advise of other strategies, such as the employment assistance program for staff, where there can be short-term individualized counseling that people may not need to access, you know, if they don't want to go through and establish a formalized relationship through their insurance. See, I feel like there's questions coming in that I'm not being able to access. Okay, but in any case, so I think, and the San Francisco Health Department has looked, has some tools out there about becoming trauma informed throughout the system. So that may be something, as this becomes an ongoing situation, that health departments, to the extent that there's any resources or energy to take that step back and look at what kinds of interventions can we make system-wide to support staff and better serve the community. I am getting a message to that it's time to conclude. I really appreciate people's attention and interest in these really important concerns. We've all gone through this pandemic. There are really widespread mental health ramifications, most of which are normal reactions to an awful situation. And there's real cause for concern, increased legal intervention and creativity, just as we moved from looking at nutrition and physical exercise as individual concerns to looking to things where we can change the environment to get better results. So too with mental health, we can change the focus from individuals to system-wide interventions. And I think that gives a lot of hope that we can really experience this idea of post-traumatic growth and maybe have more social connectedness and more social cohesion through the support of some of these strategies that we've discussed. Anyone who has, a question that you weren't quite ready to formulate right now on this short window, we do have a question and answer session at the end of the day at 2:45 Central Time, 3:45 Eastern Time. I'll be joined by my Northern Region colleagues, Betsy Lawton and April Shaw. Will be talking more about mental health and well-being, as well as broadband access and closing the digital divide, which Betsy will be presenting on tomorrow. So there's an opportunity for more informal discussion and back and forth later today if you're mulling over some of these concepts or trying to implement them in your jurisdiction. I'm happy to discuss that more later today. Thanks so much.
Yeah, thank you, Jill. That concludes today's session. If you asked any questions that did not get answered, you can reach out directly to one of the speakers by sending them a message, or you can attend one of our networking sessions at 3:45 p.m. Eastern Time on Thursday, like Jill said. Please press the button underneath this video feed in Pathable to take the evaluation for this session. And thank you all for attending and have a great rest of your day.